Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jennifer Blanchett. In today's episode, Dr. Sharon Lewin and Dr. Don Smith share their thoughts on some of the most important new HIV insights gained during the past year in the context of HIV care in Australia. Specifically, the faculty discussed the continued dominance of second-generation integrase inhibitor-based regimens as mainstay HIV therapy, the emergence of two-drug long-acting injectable therapy as a switch strategy, the successful implementation of widely accessible oral PrEP, the potential role of long-acting injectable PrEP, and key new advances in HIV cure research. For more information about our guests and for additional online education on this topic, please visit the link in the show notes. So now let's turn it over to Dr. Lewin and Dr. Smith.
Don, lovely to be chatting with you again, and it would be wonderful to hear a bit from your perspective on an update on where we are with HIV treatment in Australia.
Hi, Sharon. Yes, great to be catching up again. Really, 2022 was a year of an opportunity for reflection, I think, on the way we manage HIV, and particularly forced that way, I think, because of the COVID pandemic and the way we needed to adjust our services to try and cope with staff shortages and lockdowns, inability of patients to access what we thought was necessary routine treatment. So one of the things I think take-home messages from 2022, there's a few there. One of them that got me was that the ability that we had to maintain most of our patient group on treatment despite all the disruptions that were going on at the time. And I think partly that's because treatment has become much easier and much more effective in its ability to suppress the virus. So I have been struck by a number of years of just how much we've moved over the last couple of decades to rely on the second generation integrase inhibitors, particularly dolutegravir, bictegravir, as the mainstay of treatment. And that's meant that our earlier years in HIV of looking after drug resistance failures, compliance issues, and drug toxicity have become less and less of an issue for the majority of people. So at the moment, we probably in Australia have somewhere around about 97% of everyone who knows they have HIV is on treatment, and they have multiple access points to that treatment. So either through sexual health services or based, usually ID services, or trained general practice services, there is an opportunity for everyone to get access into the healthcare system, which I think is great. And I know that looking at trends, say, from the Kirby reports over time, the proportion of people that are now being treated with those second-generation integrase inhibitors has steadily climbed to over 70%. I think in our service, more than 80% of everyone is on one of those. So I see it as an improvement in terms of it's almost like abandoning the petrol car with electric options coming available in a way, that we're giving up on what were the necessary but hard work drugs to get onto easier ones. And the potency of those second generation integrase inhibitors, I think, is so dramatic that you often don't need that third drug in the combination to cover all the variations of HIV that are around. So particular studies have highlighted, like the Tango study, that two-drug therapy with dolutegravir and lamivudine is equally as effective at keeping HIV suppressed as a traditional three-drug regimen. In a way, it's made life a lot simpler for us as clinicians. Basically, if a patient comes in who doesn't have any baseline drug resistance or past drug resistance, then you know that a two-drug regimen with dolutegravir-based therapy is going to be fine. If you're not sure, based on where they've been over the past and their long-term treatment history, then I think a lot of us are using Biktarvy to cover the potential options of background nucleoside resistance. And the end result of that is it's actually very effective. Now, the other thing that's obviously happened in 2022 is we've been able to gain access to the first generation of injectable therapy. So that means for a lot of patients who are getting a little bit weary of taking that pill every day or concerned about who knows that they have HIV, then the option of a 2-monthly injectable therapy is actually quite appealing to them. So we're seeing a steady uptake, and certainly most of the year, once patients were able to get back into the clinic, was asking or discussing the feasibility of that 2-drug injectable option for them. They're having some challenges on the implementation side because as this treatment has become available, we've also been suffering quite a lot from staff shortages due to the long-term effects of COVID on staff mental health and retirement and challenges with replacing some of the staff members. So those have meant that there has to be a more concerted team approach to people who want to go on injectable therapy, really about what to do if they don't show up for that scheduled appointment and what plans are in place to make sure that they don't fall into subtherapeutic levels while they're not engaged in the service. So those, for me, have been the highlights. I know that about the last remaining drug toxicity that we've left to talk about has been weight gain, and that's really been across the board for a lot of patients, often driven by social media, as it is these days, that the concern has been raised on social media and it's become a community concept that certain of the drugs will induce weight gain. Now, while that didn't seem to be a concern before the first studies out of Africa raised that as a problem, more and more patients have been struggling with that. Now, I think it's quite challenging for us because clinical trials have clearly shown that either the second-generation integrase inhibitors or TAF-based therapy are both associated with an increase in weight compared to older regimens. But for me, that's not always enough to give up on the benefits of the integrase inhibitors in terms of their ability to maintain viral suppression long-term with no toxicity or very little toxicity. So this is, I suppose, the question for us when people are saying, I'm put on weight, is it your drugs that have done this? Then for me, it's yes, potentially they have, but the weight gain in the general population is also going up. We're living in a calorie-rich world these days, and patients are getting older. So I have a number of patients who've been telling me about when they were diagnosed in the 1980s that they never thought they would get this far in their journey. So I think that's quite a challenge to us as to how we will adjust, or should we modify what is a very effective therapy because of this weight gain issue. And yet in the background, there's been no proper mechanism to account for why this happens. And nor has there been any good studies showing that switching antiretrovirals will actually change that weight gain. So even in people who dropped their TAF, say in the Tango study, their weight didn't drop because of that. And I think there's always a challenge, do you want to get rid of the integrase inhibitors when they've actually proven in virtually every clinical trial to be superior virologically to any other therapy? To my mind, I don't want to go back to the days when the virus was able to break free of drug treatment, and then we're trying to tackle the problems of resistance and more complicated therapies. And then lastly, always in my clinics, there's always at least one person who will be asking about, I've been doing this for 30 years. The virus hasn't been found for a couple of decades now. Do I need to stay on therapy? So in that regard, there's still a lot of, even though the virus is under control, people are still living with HIV and still living with the consequences of their HIV, even though it's not affecting their immune system or not able to be passed on. So there is still at the back of their minds this hope that we're getting to the day where we can finally eradicate that last tiny little remnant of the viral reservoir. And that's where I thought perhaps, Sharon, you might be able to give us an update on where things are happening on that front.
Yeah, well, thanks, Don. It's a really exciting summary of where we are with treatment, and of course in a great position in Australia where we can access treatments that physicians think are optimal. But also very pleased to hear that many of your patients are still asking you about cure, because ultimately that's what we need for people living with HIV. And over 2022, there has been quite a lot of interesting advances in cure research. People always say to me, when will we have a cure? Impossible to say. This is a really tough issue scientifically. But if I could just highlight a few of the successes over the last year. First of all, I think one of the most exciting advances are the new technologies that allow us to understand the reservoir at a single cell level. And that's, for me, totally space age kind of stuff. As you know, only about 1 in a million cells in someone living with HIV on antiretroviral therapy will be carrying intact virus. There's a few more that carry defective viruses. But we've never been able to pull out the individual cell that's infected because it doesn't look any different on the outside. So we can't use all the standard techniques that we have to pull out rare cells. But using new kind of single cell sorting strategies, we can actually now dig deep into an individual infected cell. And we're learning that individual infected cells that contain intact viruses have some distinct capabilities to survive and express certain genes, and that gives us new targets for treatments. We've also learned that actually if you can distinguish between intact virus and defective virus, intact virus decays more than we initially thought happens, which gives us some hope that maybe on long-term ART, the reservoirs in some people will eventually disappear, but we still need clinical trials to prove that. The other interesting new data, of course, are the cases of cure. They continue to be reported. They continue to get lots of general media coverage, which is because people living with HIV are so interested and inspired by these cases, but they're also very important for the scientists. We've heard about 2 new cases of cure following a stem cell transplant from a donor who's naturally resistant to HIV or someone that lacks the receptor for HIV, CCR5. So that means the donor cells are resistant to infection once they're in the recipient's body. And there's now 5 reports of such individuals. And that's really exciting. One of those was in a woman reported from New York this year. One of those was in an elderly gentleman who's had HIV for a very long time, showing that this indeed can be achieved, and in women and also older people. Now, of course, this doesn't mean that we can use this approach with everyone living with HIV. All of these people had an underlying blood malignancy requiring transplantation, and that's why they received the bone marrow transplant. But it does help us work out other ways we can eliminate CCR5, which you can actually do with gene therapy, using gene scissors to target the CCR5 molecule. And those clinical trials started about 5 years ago. They're still continuing. There's incredible advances in gene therapy because traditionally for gene therapy, you need to pull out the cells you want to edit them in a laboratory and then reinfuse them. A very complicated process, and of course doesn't get every single cell. And now we've got the ability to do in vivo gene therapy, meaning that you can inject the gene scissors. And so now we can use in vivo gene therapy with different modalities for gene editing. CRISPR is one of them, but there are other approaches to gene editing. And the first gene editing study of people with HIV targeting the virus itself opened in September 2022 in the US, which is very exciting. And the last exciting area, I think, in clinical trials for cure have been how we use antibodies. And antibodies are a form of an antiviral needed to be given traditionally as an infusion. For COVID, we've been giving antibodies intramuscularly, but still for HIV, these antibodies are given as an infusion. So they're developed as antivirals and do have antiviral activity, but they've also been developed for cure because antibodies will recognize a cell that is infected, and also antibodies stimulate the body's own immune response. And in a trial reported this year, antibodies given with ART at this time of initiation of ART resulted in better clearance of the reservoir and a larger number of people that could stop ART without viral load rebounding. So we're learning a lot more about when these antibodies are best given, and it looks like giving them at the time of ART initiation really does give some benefit.
Excellent. Thank you very much for that insightful overview. I have to say, Sharon, and perhaps you can enlighten me a bit more, I've always been a little bit confused with the role of antibodies in that I remember some 30 years ago when I was first learning about HIV that Tony Fauci was telling me just how variable the virus is, way more variable than something like, say, COVID as a virus. And then seeing that in COVID treatment, those antibody treatments are no longer being used as much because the virus has evolved to escape them. Do you think that that's a possibility of happening because of the huge variability that we see in HIV, that they may have to be like matched to a patient's viral type or sequencing to try and cover as much of the variation that's there?
Yeah, resistance to antibodies is a big issue, no doubt about it, in HIV. First of all, the antibodies that are used in HIV are a little broader than what you need for COVID. So these antibodies that have been used as therapeutics for prevention and now for cure are commonly called broadly neutralizing antibodies, or BNAbs, meaning that they recognize a very wide range of viruses. But the two BNAbs that have in most cure studies now being developed, about 10% of people will have resistance to both of them, and about 50% of people will have resistance to one or the other antibody. So yes, these studies do require some screening to understand the virus that the person has. And the benefit when we give these antibodies is really only seen in people that have the sensitive virus to one or the other antibody being tested. So the issues of resistance to antibodies is an important to do with BNAb work, both treatment, in all areas, treatment, prevention and cure, but we overcome that by pre-screening and using antibodies in combination.
Excellent. Thank you for that response.
And Don, just before we wrap up,
yes,
because we're focused heavily here on treatment, but obviously prevention is another very exciting area of HIV currently, and Australia's done an outstanding job of being able to deliver PrEP, probably way above most other countries. So tell us a little bit about what's new in prevention.
Thanks, Sharon. Look, I think with the way certainly the Australian healthcare system has picked up PrEP and run with it and engaged with it in a more of a standard practice way rather than a research way has meant that within a year or two of those studies showing that it's effective, it's being rolled out really targeted to those people at highest risk of HIV. So any doctor in Australia now can prescribe PrEP to any of their patients. So we have that available. There are some limitations to that, particularly that we only really have the first generation PrEP option of TDF-FTC available to us, whereas in other countries, many people have transitioned to TAF-based oral dosing so that you can avoid the renal and bone cumulative toxicity that's associated with that. And other countries have also been able to access injectable therapy as a PrEP option. And while that's very expensive and quite demanding on the healthcare system, that has been shown to be much more effective. And certainly from the patient perspective, where they may not know when their next high-risk encounter is going to come, having therapeutic levels of drug in their system from an injectable is obviously where we'd like to be with that. And I think with that widespread availability of PrEP in the country, plus the high levels of effective treatment coverage in those people with HIV, we're in a situation today where there is actually very little HIV in the community. And certainly over 2022, I have seen large numbers of gay men with a whole range of STIs, but I haven't seen any new cases of HIV in that time. So I think both the implementation of PrEP together with widespread treatment accessibility has meant that community HIV levels have virtually disappeared in the country. So we're left in the stage of trying to maintain that and not get any fatigue in the system as people have to stay on their therapies to maintain those benefits. I'm hoping that as we get into 2023, we may have a few more options for treatment, particularly the injectables.
I agree, the injectables will be important. And it really is encouraging hearing you to say how little HIV there is in the community, though just, of course, important for people to know there's still 500 plus infections in 2021, but the lowest ever new HIV infections in Australia since we started diagnosing people with HIV. So we're heading in the right direction, but we've still got a way to go to see the elimination of HIV in this country, but this country is potentially a country that could achieve that. And just in closing, I might just make sure that you, of course, will be at the IS Science meeting in Brisbane, which is going to be held in the end of July 2023. It'll be great to see all of our Australian HIV community supporting that.
Excellent. No, I wouldn't miss it, Sharon. Looking forward to getting the latest updates there. And from my perspective, just in closing out, when you're talking about, that there are still new cases being diagnosed, many of those are people who've been infected many years ago who are just presenting to the healthcare system. And I think it highlights for us also the need to normalise HIV in the health system so that those people don't feel afraid to present or get tested rather than having to wait until they're on the cusp of an opportunistic infection before we finally identify them. So for me, it's actually trying to take away a lot of the stigma of HIV so that people can live as much of a normal life as possible, and also acknowledge the great success we've had over the years in improving the living standards of people with HIV.
Great. Thanks very much, Don.
Thank you, Sharon. Always a pleasure.
Thank you, Dr. Lewin and Dr. Smith, for sharing your insights with us. And thank you for listening. Look out for more episodes in this series at clinicaloptions.com/HIV.